Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Safety and Survival with GVAX Pancreas Prime and Listeria monocytogenes expressing mesothelin, CRS-207, Boost Vaccines for Metastatic Pancreatic Cancer, by Dung Lee and others. My name is Howard Kaufman, and I am the Associate Director for Clinical Sciences at the Rutgers Cancer Institute in New Brunswick, New Jersey. My oncologic specialty is melanoma and tumor immunotherapy. The manuscript by Lee and others describes the results of a randomized clinical trial using cyclophosphamide and intradermal GVAX, followed by boosters with intravenous Listeria monocytogenes encoding mesothelin. GVAX is an irradiated whole-cell allogeneic vaccine engineered to express GM-CSF. The rationale for this regimen is that GVAX will encode one or more shared antigens with pancreatic cancer cells, resulting in priming of CD8-positive T-cell responses through cross-presentation of shared antigens by GVAX and augmented by local release of GM-CSF, which helps to recruit and mature antigen-presenting cells. The cyclophosphamide is used to deplete regulatory CD4-positive T cells prior to T cell priming, although the impact of cyclophosphamide for depleting regulatory T cells is somewhat controversial. GVAX and cyclophosphamide have been studied previously and found to induce T cell responses, but alone did not promote significant clinical responses. In this regimen, patients are boosted with the Listeria monocytogenes bacteria encoding mesothelin, a known pancreatic cancer antigen. The Listeria is engulfed by antigen-presenting cells, releasing danger-associated molecular patterns capable of inducing innate immune responses, while mesothelin should be presented and help boost mesothelin-specific CD8-positive T-cell responses, thus enhancing the immunologic assault on tumor cells. In this randomized clinical trial, 90 patients were randomized to receive the combination therapy or GVAX cyclophosphamide alone. The population was patients with previously treated pancreatic adenocarcinoma. The primary endpoint of the trial was overall survival. The authors demonstrated that the combination regimen was associated with a significant, albeit modest, improvement in overall survival, extending life by 2.2 months in the intention-to-treat population and 5.1 months in a pre-specified per-protocol population. The authors also measured the frequency of mesothelin-specific CD8-positive T cells in the peripheral blood and found that patients who had higher levels of mesothelin CD8 T cells also had better survival compared to those with a minimal or absent T cell response, supporting the immunologic mechanism of action for this combination therapy. The toxicity profile appears reasonable, with most side effects reported being low-grade constitutional-type symptoms. The study highlights several important principles of immunotherapy for the treatment of cancer. Let's explore some of the key questions about this study. First, what is the regimen used by the investigators and how does it promote anti-tumor activity? The study employed a combination approach using three distinct components. What are these? GVAX is an irradiated allogeneic whole tumor cell product that expresses GM-CSF. GVAX acts as a vaccine by providing an array of shared antigens for priming a tumor-specific T-cell response, and local GM-CSF release promotes the uptake of the cells and maturation of antigen-presenting cells such as dendritic cells. GVAX has been extensively studied as a monotherapy against a variety of cancers with only limited therapeutic activity. In this study, GVAX was administered with cyclophosphamide, which is used as an adjuvant to deplete lymphocytes prior to T-cell priming and likely inhibits the activity of regulatory T-cells, which can suppress T-cell priming. In addition, this study boosted patients with the Listeria monocytogenes bacterium encoding the pancreatic cancer antigen mesothelin. Listeria is engulfed by antigen-presenting cells, and theoretically the mesothelin will be expressed as processed peptides by these antigen-presenting cells and will prime mesothelin-reactive T cells. Are all three components necessary? Although the authors could not directly address this in their study design, they did have preclinical animal tumor data suggesting that therapeutic responses were dependent on including all three components. Further, they did measure mesothelin-specific T-cell responses and found a correlation between clinical responses and the appearance of the mesothelin-specific T-cells in patients. Why does this regimen seem to have therapeutic activity? This question could not be answered in this trial, but there is emerging evidence that combination approaches with two or more immunotherapy agents may be more potent than monotherapy. Clinical trials of the T-cell checkpoint inhibitor ipilimumab, which targets CTLA-4, and pembrolizumab, which targets PD-1, have both demonstrated a survival benefit in randomized studies for the treatment of metastatic melanoma. In a pilot trial combining ipilimumab with another PD-1-targeted monoclonal antibody, nivolumab, a clear synergistic therapeutic response was seen, prompting a larger randomized clinical trial, currently in progress. Further support for combination immunotherapy can be found in murine studies of tumor immunosurveillance, which has suggested that complete tumor elimination may only be possible when both innate and adaptive arms of the immune system are engaged. The approach used in the Lee and others paper likely engaged both innate and adaptive immunity. The listeria likely helps activate components of the innate immune response, while the GVAX and mesothelin expression help to induce adaptive CD8-positive T-cell responses. Further study into the mechanisms by which this and other immunotherapy regimens mediate anti-tumor effects should be high priorities. Finally, we should ask about the potential opportunities and challenges of immunotherapy for the treatment of pancreatic cancer. In this study, the investigators selected a particularly challenging population of patients with advanced pancreatic adenocarcinoma who had failed previous therapy. Perhaps it is not surprising that immunotherapy may be effective in this disease, since pancreatic cancers are known to be associated with inflammatory reactions. We now understand, however, that lymphocyte-predominant inflammation may help promote immunotherapy, while lymphocyte-poor chronic inflammation may inhibit successful immunotherapy. Although we incompletely understand why some tumors may promote a predominant lymphocyte reaction, future studies will likely explore the lymphocyte status of tumors before and after treatment as a method to better select patients likely to respond to immunotherapy and validate local lymphocyte responses as a predictive biomarker. This study also highlights two unique features of tumor immunotherapy worth mentioning. First, clinical responses may be delayed due to the kinetics of immunotherapy, which indirectly controls tumor growth. Thus, by using an overall survival endpoint, evidence of activity was demonstrated, whereas objective responses were not observed. Second, the toxicity profile for immunotherapy is very different from cytotoxic chemotherapy and targeted therapy. In this case, side effects were mild and well tolerated, a major advantage in this advanced patient population. While this study is promising, the trial has a number of limitations, including the relatively small sample size, and larger prospective randomized clinical trials are needed to confirm the potential benefit of this combination immunotherapy approach for the treatment of pancreatic cancer. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.